Bonjour tout le monde, bienvenue à Bruxelles. My name is Charles Guttridge. I'm one of the SNOMED staff and working with Ian Green this morning, going to host this session. You're probably all aware, but there are people on Zoom, so this is a hybrid meeting. I think there's about 100 or so people in this room, and we think of something like 300 or 400 people on Zoom. The point of emphasizing that is that when we get to the question session of each section, it is very important that you wait until a microphone is brought to you so that the question can be held by those on the Zoom part of this conference. You're also probably aware that the presidency of the European Union is handed over every 6 months, and currently the presidency is held by Belgium. And we're very, very grateful that Belgium has invited SNOMED to host this conference, and we've been supported by the Belgian team, and it's one of the initiatives of the Belgian presidency in relation to health and health delivery across the whole of Europe, and which is obviously an important aim of the terminology and an important aim of all of us, whether doctors like myself or administrators of health. This is an amazing way to get our message over. I'd encourage you, as each person speaks, to think out some questions. If you're silent, Ian and I will produce questions, but we'd really like yours. And what I'm going to do is, after each presentation, ask the speakers to sit up here, and so you can sort of begin to commune with them in your question thinking. So, without further ado, I would like to introduce you to Don Sweete, who is the Chief Executive of SNOMED International, and is going to introduce the session. Welcome, Don.
Thank you, Charles. I want to thank everyone for coming. I know these are busy times. When is it not busy in healthcare? I want to thank the Belgium team. They have been outstanding in continuing to push us as an organization, but also quite gracious in having us here for the first SNOMED CT day in Europe. Apparently I only have 10 minutes, so I'll whip through it quickly. So I want to talk a little bit, and this really sets it up for the 2 days. We've been talking about, and some of us gray-haired people in the room, I'm looking at one of them now, we've been at this for over almost 40 years. And 40 years ago, it was a glimmer in someone's eye that we would have interoperability and patient information would move with the patient just like your bank card. Your money moves with you, so you can use it. You can see what's happening. And so the promise was 35, 40 years ago that this was going to happen immediately. As we can see, it has not. And on the screen, it really talks about the definition of interoperability. I'm not going to read it, but essentially it means that if you have the data and you have it in the medical context, and you as a citizen or a patient or a clinician can view that information, then everyone can make informed, safe choices. And that information should move from system to system and mean the same thing. There are a number of problems that have cropped up lately. These are not new, but they've become more, I guess, critical in nature, especially where health systems are seeing reduced people working in the health system, more people moving about the globe, picking up new homes and finding new jobs and living in different countries. The first one, and this is not new, the international cross-border patient movement piece, Europe was the first to look at this a number of years ago with a trial project called EPSOS, which was a resounding success, of which our organization played a small role in. And then it was dormant for a while, but now it is certainly moving forward post-haste. Informed unscheduled care. When you look at what happens in the emergency room, how do you know what the patient's allergies are? What do you know what his underlying conditions are? How does a clinician who sees them for the first time, and this patient may be unconscious, how do you deal with understanding what you have to do in order to potentially save him or treat his illness without causing an adverse event? One of the things that we found out from the pandemic is we weren't very good at sharing data and moving it within our countries, let alone across borders, so that you could start to have a better understanding of what was happening to populations, what some of the symptoms and diagnoses were, and more importantly, what were the different treatments used in order to treat patients. So this needs to improve, especially as the globe is changing. You look at climate change, there are a whole host of things that are happening in the world today, homelessness, which creates a whole different way of treating a patient. So we need to do something about that. And lastly, the governments are the ones that fundamentally provide the direction and the monetary support to make healthcare systems work. It's hard for them to focus the money in the right areas if you don't have data that allows them to do population health management, so you can actually see that perhaps in 3 years or 5 years, there may be a different type of disease that is cropping up within your population. I think someone said that probably about 60% of the population really don't see their healthcare providers, and if they do, they probably lie about their health status. And so how do you find out whether or not those are one of the invisible walking wounded that will come in at the last minute with a severe illness and gobble up huge healthcare dollars, and in the end may not be able to stay alive because of the fact that they waited so long. If you look at Europe, you are number one with a bullet. If you look at the various initiatives that are happening around the globe, you're the ones that are out in front, and you have been certainly since the early 2000s. I've watched with great interest, and we provided a paper on the European health data space. This is exciting times. I come from a country where I don't get to see my information, let alone understand whether or not I can have the ownership of it or have the viewership of it. So this is groundbreaking stuff. And the fact that the European Union did it with so many different countries that came to the table, and in the end, compromise was worked out. I do want to thank the European Union for helping member states with moving to SNOMED International. We have pretty much all of the European Union countries now members of SNOMED International. So we certainly thank them for that. And tools of change is a big thing. The European Commission is driving things in Europe. From a global perspective, the G7 made an announcement in 2021. That really kickstarted the work on the IPS, or the International Patient Summary. That was taken up by a larger group of companies called the Global Digital Health Partnership, and we've seen XShare, which is widely being talked about and worked on in Europe, but also viewed by other countries as something, a model that they may use in their own countries. And lastly, we have the IPS, which to me is a starting point, but a very robust starting point. This is the statement that the G7 made, and then it was endorsed by the G20. And really, to have the largest countries in the world step up and say this is a priority for us is a very big deal. It really spurred people into action, and people are moving forward very, very quickly to move forward with the International Patient Summary. The IPS is really just building a bridge. It's a starting point. You can see on the left-hand side that some of the things that are in the International Patient Summary now, and each country Certainly, my country has not only the International Patient Summary, they also have a core set that attaches to it to help them move information outside of that patient summary throughout our very large country. But the key for this one is we defined a use case. And the use case is really what happens when someone appears at a hospital, they're unconscious, and they need treatment. What do you need to know about that patient to provide efficient, safe, and effective care? And that was really the starting point a number of years ago. It's not done by any one organization, certainly not done all by us. You see here that the European eHealth Network is involved, as well as SEN, ISO, HL7, our organization, LOINC, DICOM, GS1, and IHE. And there will be many more standards organizations that will form part of the IPS as it grows and it becomes more mature. Where we fit is really, we have a global terminology. We are not all things to all people. We like to work with others, and you see from this map, the number of ways that we interact with various standards organizations to essentially link everything with an electronic health record, so the information is very comprehensive and very understandable, and when it moves, it can mean the same thing in other systems as well. Looking forward from an organizational perspective, we have been challenged by our General Assembly and by our board to evolve SNOMED CT into something that is foundational, not all-encompassing, but foundational, that it deals with today's issues, that it becomes simpler to use, and essentially becomes more focused on the needs for potentially by region in the future, so that their needs may be somewhat different than others, so why not have an international release that is regional in nature rather than one that covers the globe. We also want to create a hub for linking standards together. Picture, if you will, a day where you're an end user, a CIO, and rather than going to 5 different standards organizations to download that specific standard and their implementation guidance, and searching through which is best, and then trying to figure out whether you have the latest version, wouldn't it be nice if 5 standards organizations got together and released a package that provides that implementer the choice of essentially being able to download once, implement it once, and use it once. The other piece, and it's hitting us straight in the face, is artificial intelligence. Machine learning has been around for a number of years. That really hasn't changed. Is AI real or is it hype? We don't know yet. The concern for me personally is whether or not it's safe. Does it have biases? Does it use the right foundational information to provide the clinicians with the information they need to make a choice that will be beneficial to that patient? So we are developing an artificial intelligence strategy. Within that strategy, there are 3 prongs. How can it make us more efficient and more effective? Secondly, how can we produce something for our member countries that allows them to leverage the power of AI to safely move things forward in what they do? And lastly, similar to what we did with the Bomni project, where we provide a free open source coded EMR, we would like artificial intelligence to be part of something like that to eliminate one of the biggest problems we have in healthcare, which is clinicians actually using drop-down boxes to code the information. Let's solve that problem and then have the clinicians deal with the patients directly and have everything else go on along in the background. And lastly, we wanted to ensure long-term sustainability for the standard itself. It's been around since the 60s. There's been hundreds of millions of dollars put into it, certainly by clinicians. College of American Pathologists developed SNOMED, and it was combined with Reed from the United Kingdom a number of years ago. It would be nice to have that continue and evolve over time. This is where we want to get to. We want to give everyone a choice. We want to be able to enable citizens and patients to have better control over their health information and participate in active discussions with their healthcare providers about what they want to do. It's their choice. and it should happen regardless of location. Lastly, I want to tell you a story. I'm probably over time, but I'll tell it anyway. 35 years ago, a patient fell and broke their hip. After a 20-minute wait for an ambulance, they went to a hospital. That patient sat in the hospital for 3.5 hours until they collapsed due to respiratory issues. That patient was put in emergency. They had 2 days to figure out what was going on, and they only had the information that that patient brought in. That patient was transported to a large tertiary care center by hospital, and 3 days later she died. And the reason that patient died was because no one had information on her relevant medical status, and they treated her based on what they knew rather than the history of the patient. The patient that died was my mother. So I am driven and have been driven for 35 years to get everyone in the world to a point where their information is there for the clinicians to help save them. So thank you very much, and look forward to questions later on.
Thanks very much, Don. Outstanding introduction and a moving tale, most of whom I would guess in this room could replicate a story a bit like that in one form or another. And so this is the real part of, I think, modern healthcare delivery using digital tools. But now it gives me enormous pleasure to welcome Nick Marley to the stage. Nick is an advisor to the Belgian government and is going to give us, I think, an overview of what's happening here and how it all links to our agenda for today. So welcome, Nick. Thank you. Take a seat.
Okay. Good morning, everyone. Thank you, Don. Thank you, Charles, for the kind opening words. And yes, everyone has these stories, and I also have a story about my mother in her last weeks, and that they also said, why isn't it possible to share data better? To start with her medication, for instance, which was not shared correctly. Welcome, and I have these slides here. Yes. Welcome and thanks to you for participating in this European SNOMED CT conference. I hope it's going to be a great experience for you all. We are proud that we can host this event. I got 30 minutes, I think, so I will take my time. I would also like to say, Don said a big country should say we adopt SNOMED. Yeah, Belgium is big in beer and chocolate, so Belgium is going to say that we adopt SNOMED CT. That's the main focus of my presentation. I hope you enjoy the chocolates and the beer, of course. So we are looking forward to welcome you also in Antwerp, where you have the SNOMED CT Expo in October. SNOMED CT we are convinced that SNOMED CT plays a crucial role in standardizing and improving the quality of healthcare data, enabling interoperability between different systems and providing a common language for healthcare professionals to communicate effectively. As the healthcare landscape continues to evolve, the importance of SNOMED CT in driving innovation and improving patient care cannot be overstated. Over the next 2 days, you will get a lot of information about how Belgium uses SNOMED CT, how it plans to implement it, what we have been doing up till now, with also the help of some budget coming from the resilient funds that a lot of countries have put into place after COVID-19. And the fundamental role of SNOMED CT that's playing in what we call the Belgian Integrated Health Record. So you will also have some presentations, I think, about the Belgian Integrated Health Record and this concept. I will come back to this a little bit later in my presentation. I don't have to convince you that the usage of uniform clinical terminology and electronic health records across Belgium will lead to better health, better patient outcomes, and greater involvement of all citizens in making informed health choices. Also, secondary use of health data depends on well-registered, well-documented data. We are also trying to make this happen so that researchers and policymakers will also have access to detailed clinical data from a wide range of healthcare systems and will be able to perform meaningful and targeted searches thanks to relevant clinical details. Now, let us go a little bit more in detail how we try to do this in Belgium. The first two pictures I snapped from the internet. I have the references if you want to have them. How do we try to do this in Belgium? Well, we have what we call the quintuple aim. We have 5 goals, 5 objectives that we have defined in Belgium. That is creating a better care experience for our patients. I will use a little bit patient, citizen, person, individual, healthcare user in the speech. They all mean a little bit the same thing. It's about a person that needs care or that wants to stay healthy. We want to create a healthier population. We want to do better with the money we get, not reduce, not increase, just continue with what we get and try to be more effective. We want to ensure an accessible healthcare and improve, very important, improve the well-being of our healthcare workforce. We have seen during COVID-19 that they are really key in managing a pandemic crisis, and we have to take care of them. We also notice a real paradigm shift in care. Care is no longer or less about only disease and only cure, it's about the person. We see more and more chronic and multiple pathologies. We see multidisciplinary teams taking care of a person, and not only healthcare professionals, also people in the ecosystem of the person, family, friends, neighbors that take care in this care process. So we have to be able to provide information to all these people how the care should be supported. There's more attention for prevention, for well-being, as well physical and mental health. This will all the differences between mental health, physical health, well-being, that will fade. It will become one part as it should be, focused on the person. We're also evolving towards a more outcome-based healthcare system in Belgium, lump sum paid, lump sum financed. And yeah, secondary use of data becomes extremely important, and for this you need really standardized interoperable semantic understanding of data. What we are also focusing on, and this will be also one of the main threads in Belgium, that is integrated care. Integrated care, you can understand this in a couple of ways. I'm still on the first slide, don't worry. But next slide, I will show you more the systematic integration of care, where you can ask that systems work together, technical systems work together in a hospital, between hospitals, in networks of hospitals, between the system to share data in Belgium, of which you will for sure still have some input during the next coming of days. Also with the first line, it's a pity that if you go to a hospital operating quarter and the surgeon doesn't find it important to read your patient summary, what's in Belgium called your summarized EHR, because there is no information in it. I don't have a summer, for instance. This means maybe that I'm a healthy person, but I don't have a summer, which is a pity. So integration on the systematic level, integration also on governance level. We have a lot of levels in Belgium. If you don't know yet, Belgium is a very complicated country, next to the beer and the chocolates. And we need to work together. We have seen this, it's possible. It's really possible. During COVID-19, we have seen that we can work together, that we can create legislation together, that we can manage a pandemic together. And we even did it better than some other countries with less levels of governance and with less political levels. But still, it remains a very complex country. It has the advantage. It means that you have to be interoperable. We need to be interoperable, otherwise we don't work together. It's very simple. Another level of integration is across care lines. Zeroth line, patient, first line, care, second line care in a hospital or a healthcare institution. So integration is multiple levels, and we are going to shift a little bit what we call the e-health action plan, the actions that we have for digitization healthcare in Belgium. We're going to shift this more and more towards this concept of integrated care, what I also call end-to-end care delivery. We have in integrated care a number of programs concerning the unborn child, mother, family, and the first 1,000 days, we call this. We also have a program, integrated care, concerning obesitas. We have a program, integrated care, concerning chronic diseases. We're going to work around these concepts to do the digitization necessary to support these integrated care paths, end-to-end care. So it's not specific projects, it's not specific data sets that we're going to implement. We're going to implement the data sets that are necessary to support this and deliver them end-to-end. An important aspect of this is what we call the Belgian Integrated Health Record. As I mentioned already, Belgium is a complex country. Our data is distributed in Belgium. There is no central repository for healthcare data. We make it work. We have the possibility to find out, to share data, to find out where this data is localized and to access it. To make this available, this data available, we have to have a common concept of what is an integrated health record. So the Belgian Integrated Health Record is an initiative, is a concept that we're going to deploy the next coming years. It doesn't mean that we're going to centralize data. We're going to make sure that data is available. And I'm going to come back to that later on in the speech. We also have the action plan, as I mentioned. We have a e-health platform in Belgium that is responsible for the basic services like user and access management, like messaging between healthcare providers, like access logging, how to find data that has been shared of a certain patient. So all these systems are in place and can also be used in a cross-border context like we will have linked to the European Health Data Space. We have also put into place a Belgian Health Data Agency. This is more for the secondary use of data and wants to make sure that healthcare data is available for research, for innovation, for academic purposes, for policy making. And for this, of course, I don't have to tell you, SNOMED CT plays a key role. I'm going to go to the next slide. Some numbers about e-health. In Belgium, only 3 I'm going to focus on. Informed consent. This is a consent that every Belgian has to give to share data in Belgium. That is the data sets that have been defined that are shared, like lab results, like vaccination information, like intolerances and allergies. These informations are shared. And you have to give a consent for that. This means that a physician or a healthcare provider with a therapeutic relation can have access to this information or some of this information. It's going to evolve. The person will have the capability to say, I want to have access to, I identify this as something that my physician can access or not. You will have, a person will have more capabilities to tailor this to his specific specific requirements. 95% of Belgians have given their informed consent. This has been happening in a period of more than 10 years. We are with almost 12.6, 12.7 million Belgians. We are already over 11 million people, so 95%, which is a great number. And we are never going to recall this. If you would ask again, informed consent of all Belgians, that would paralyze our healthcare system and the sharing of healthcare data. European Health Data Space, a lot of people will come back to this. European Health Data Space asks for an opt-out for primary sharing of data. We have already an opt-in in Belgium for the sharing, and it's already completely in place. Another number maybe is, portal. If we have My Health portal in Belgium, where you can, as a person, check your shared data. We have seen during COVID-19, it has given an extreme boost to the consultation of this portal, linked, of course, with the availability of certificates. And then the last one is the data permits. This is right in the bottom. There are about 190 requests that were treated last year for data permits to health and healthcare data. This is also a requirement that will come back in the European Health Data Space, but Belgium has already a lot of experience with this kind of data permits, where you check if there is a legal basis to have access to data, and if technically everything is okay to ensure that that privacy and security of the data is assured. Integrated health records. I don't know who was first, European Health Data Space or Belgium with the action plan eHealth, because it's exactly the same. We have exactly the same objectives. I'm going to think that it was Belgium who was the first, but I don't dare to say it too loudly. So I hope this is only broadcasted locally. We want to emphasize on quality, continuity of care. Want to emphasize on empowerment of the healthcare provider, empowerment of the person, the citizen. We want to facilitate the exchange of data, and that's where, of course, SNOMED CT plays a major role. We want to ensure that this information is used for innovation, for policy making, for academic and R&D purposes. And we want to liberate time for our healthcare providers. That has linked with the well-being of our healthcare providers. That's one of my biggest frustrations. I have working a long time in health and digitization of healthcare as in our local NHS, as well as the Ministry of Public Health. Each time we digitize things, it becomes more complex for healthcare providers. This is really a frustration, and I see this, the more capabilities we have concerning informatization, digitization, the more we ask to register, the more we ask the more we complexify procedures, and we have to break that chain. AI is maybe going to give some solutions, but we have to break that chain. Digitization should help healthcare providers, people that provide care, to liberate time, not take more of their time. So a big challenge. You could call this a Kafka test, but if you call this a Kafka test, that's something of 15 years ago in Belgium, so we're not going to call this a Kafka test, but we should take care of that time is liberated. This is just showing you integration, this integration aspect, different lines of care, and that you really have to take care that everyone works together and that it's not a separation, like the story of my mother. We had the nurse that came to our home, brought a little booklet. I wrote down all medication in that little booklet. It was never consulted, not by her physician, not by the specialist, not by the nurse. This should not happen. This should not happen. Medication scheme should be available, should be complete, should be up to date. We have to strive to reach this goal. Success factors. While I was making the slides, I always struggle with structure. I'm a little bit chaotic, if you didn't notice yet. There are 5 things I would like to check with you that for me are important to make a success about SNOMED CT. That is legislation, that is the organization around, that is infrastructure, incentives, very important, and I hope if we are part of a next government that this will be in the government program, because it will be a hard discussion, because there is money involved, of course, and the trust building. Going to go into a little bit detail for each of these subjects, and how much time do I still have? I'm in the time, or yeah, you didn't check. I think it's still okay.
Yeah. 10 minutes.
European health data space, you will still get a lot of information. You see the same things coming back. That's why I dare to say we copied from each other. It's about empowerment of healthcare provider. It's about empowerment of citizen. Citizen will have the right to have a transcript of its medical information. A citizen has the right to have services available. European health data space is not about the organization of care. Organization of care is still a responsibility of each member state. One of the discussions we had, Konstantin will comply with that, was the telemedicine, for instance. Telemedicine is in the European health data space, but we only talk about interoperability of telemedicine. Not about the fact that telemedicine, what happens with telemedicine, reimbursement, and so on, how this is organized in a cross-border situation, for instance. Every country is free to say we use telemedicine concept, yes or no. So it's not about organization of healthcare, it's about sharing of data, primary and secondary use. A lot about secondary use of health data and health-related data. For research purposes, I mentioned already the purposes, and a lot about EHR systems, what they have to comply with, and well-being systems, wellness systems. Also, some aspects about the governance of the EHDS and how countries should work together to put, for instance, the infrastructure in place, the services in place, as well for primary as secondary use. It's a lot about cross-border, of course, and I will come back to that briefly later on. There are other legislations that are in place. I will not discuss about them. Clinical trial regulations, the Data Governance Act, where you have the concept of altruistic organization. Last week I was at the Belgian Brain Council, who has put a data altruistic organization in place to, even at European level, to have a data sharing concept in place. But I hope that the European health data space will be the legal basis for data sharing. I'm not going to go into detail here. It's about what are the conditions for sharing data for primary use, what are the conditions for sharing data for secondary use. Primary use, there may be an opt-in per country. Secondary use, there must be an opt-in per data category, per objective. There is no limit on the data categories except for genomic data. There a country may implement an opt-in. So for the categories of purposes, you have to implement an opt-out. I'm not going to go into detail. Why do I say this? We have to make it happen. If there is a possibility of opt-out, you have to create trust that we are going to use the data for secondary use correctly. You have to create transparency. You have to create involvement. You have to create a return on individual investment of people when they do not opt out to share their data. Otherwise, you could get popular movements that people say, we opt out. We opt out. We have some negative experiences. This has been in the news. We opt out. So we have to make sure that this trust is in place. I will come back to that in the next slide. The EHDS is also has also some organizational aspects. So the first part I already mentioned. It also has concept of organization. For secondary use, it brings into place the concept of health data access bodies. I will not talk about primary use. Secondary use, health data access bodies. 3 core responsibilities you will find there. As first, assure that data is made available, facilitate this by providing a data catalog, by assuring that the knowledge of the data is there, where is the data situated, how you can get access, these issues. Secondly, it's about data permits, how we can get access to the data. And thirdly, it's about the data processing. How can you get the secure processing environment in place so that you can get access to this data? These are the 3 core responsibilities of a health data access body. In Belgium, there will be different agencies that take care of that. The Health Data Agency that has been defined in Belgium, we are in discussions with the regions that this becomes an interfederal organ. So you will have, I hope we will have one Health Data Agency for complete Belgium. And if I say complete Belgium, it's federal and interfederal. So for the regions and the communities. So there will only be one place, I hope, that you can go to check where can I find certain data. Data permit, we have something in place already since last century, which is called the Information Safety Committee, which is handling the data permits. I showed you the numbers, how much data permits they handle. So we have this knowledge and this how to operate this, and we still have to position this. And then for the processing, for the secure processing environments, I have one slide, but we have some organizations around, for instance, the insurance agencies that provide data. It's called the IMA, Intermutualistisch Agentschap, l'Agence Intermutualiste en français, that makes claim data available in a pseudonymized or anonymized fashion or way. I will come back with a slide concerning this secure processing environment. Incentives, hugely important. Hugely important. We have to make sure that data is shared in an interoperable way, and we have to create the correct conditions for this. It has no use that data is not available, is not real time, you cannot count on it. You have questions of liability if you reuse data, you have questions of completeness if you use it for secondary use, and so on. Representativeness, that's not a good English word, excuse me for that, but does it represent my case, yes or no? So you have to have good qualitative data in place and preferably standardized with SNOMED CT. What are the expectations towards our healthcare professionals and institutions? That they maintain, that they share, and that they also consult this data. That's important if you want to reduce costs, for instance, if a certain medical imaging has already been done, if a certain test has already been executed, try to reuse this information if it's still valid. You want to be sure that there is a better outcome of quality of care, and you want, of course, be sure that this has a benefit for the patients, so that you have faster healthcare recovery. What does a healthcare provider or healthcare institution get in return? That is good quality information about their patients. And this is one of the gains we expect if everyone that has access to a medical file and registers data does his work. Data should come available for every healthcare provider, and every healthcare provider should have the opportunity to use this if necessary, if allowed, of course, if he has to provide care for this patient, should have the possibility to use this. More job satisfaction. In one blink, if you have, that's what we're still working on, you should have the possibility as a healthcare provider that in one blink you can have a good overview of your patient. Having all the information you need in one blink is something that we try to establish also with the Belgian Integrated Health Record. You have this multidisciplinary team, so inclusion in the care process is important. You can do benchmarking. If you have good data, you can do benchmarking of your own functioning, of your own community, what is important for my community, for my patients. And incentives, of course, you know, that can be tangible and non-tangible, and one of the aspects will for sure be the financial incentives that I would try to focus very briefly on. We have discussions about financial incentives to register, to document data. And I hope, once again, that this will be part of negotiations of the next government. Some people say it's just part of the job. You're paid as a healthcare provider, do your job, register data, and you don't have to get anything extra for that. Some people think of, we have a premium system for using digital systems in Belgium. Using or having, we could shift this towards registering, but once again, money is involved and we will have to have discussions because it's not distributed equally. You could have a pay for performance, which includes the registration or the documentation of data. And as I said, it should be on the agenda of the next government, I hope. Other possibilities for the healthcare institutions are, for instance, the fees that are foreseen in the European Health Data Space legislation. You could also have a deal with industry. Industry will also have to pay fees to have access to data. You could say, okay, you will have to pay fees in the future if you want to have access. Why don't you pay something now? And we will put into place infrastructure based on, you pay now and you put into place the infrastructure. You don't pay fees for access to certain data sets later. It can be part of the Belgian meaningful use criteria. So part of the financing in Belgium of the hospitals is done through meaningful use criteria. Could be part of that, and we're evolving towards that also. Financing of hospitals is done on based of diagnostic-related groups. This could also be based on SNOMED CT. We have a system of conventions, care paths, lump sum for low and medium variable care. So this all could be adapted in terms of assuring that the registration of quality data is done. I think I'm almost at my one more slide after this one, I think. Yeah. For instance, also around the hospitals, we see that there is a dynamic to create a secure processing environment around the hospitals. So this can be used for internal use, of course, of the hospitals, could be used by industry, pharma industry, life sciences industry, could be used by the governments for their policy making. So we watch these initiatives carefully, and it's a very interesting dynamic existing or going on for the moment. And this all is part of implementing the European Health Data Space concepts in Belgium. We have a program, federal government program called the Data Capabilities. I have been aware of a certain of the projects. One of the projects that I found extremely interesting is that you create a closed loop with the specialist, between the specialists who register data, the data analysts who create an AI model, the ICT that makes sure that all this information, all these digital tools are available, this registration can happen, and so the ICT delivery, and the specialist who gets the information how to improve their treatment. What are still possible treatments or therapies that I can have for a certain patient? And based on this, again, registration and completing the circle. This kind of things of cooperation between data analysts, ICT, specialists, healthcare providers, we should put in place. Again, based on SNOMED CT, we are on SNOMED CT conference, so I have to say this a number of times, but based on that to make it work, otherwise it won't work. We also see some interesting projects around rare diseases. Rare disease is a very difficult one. We have, I think, 4 registrations for the moment that are being done, but there are, I don't dare to say the number, in the thousands of rare diseases. We see that with these projects, more data will become available for concerning rare diseases. More people should be also identified as having a rare disease, still one of the challenges of this thing. Most important part, if you remember something of the speech, is a trust building. Also a role of the Health Data Agency, also a role of the European Health Data Space. If you don't create trust in the concepts that we have put into place, you don't have data. That's very simple. So you have to create trust. Literacy, inclusion is an important part of that. Make sure that people know about what we're trying to do, that it's transparent. For what are we going to use your data? Primary use for your healthcare, secondary use to improve therapies, to improve medication, to improve care paths, to improve care in general, but that it's clear. Otherwise, you could face popular dynamics and opting out in general, like we have seen at a certain moment in the United Kingdom, that people have started opting out en masse. Yeah, like I said already, personal medicine, personal treatment should benefit of this, should be shown as a benefit. Healthcare has always been has always been based on a financial solidarity. People have been putting money in a pot, and if you are sick, you can take from this pot to pay for the healthcare. That is our solidarity system that we have put in place in many of the European countries. This age will be an age of data solidarity. We should make sure that people find the reasons to share their data, because data is essential to improve our healthcare. Voilà, that's it. I think the questions are for later, and I hope I have been in time.
Perfect. So thank you very much indeed, Nick, for a fascinating insight into the Belgian system. And if you were wondering whether there is a theme to this morning session, there is. So we've had Don talk about, if you like, the international scope of SNOMED, then Nick talking about the Belgian view, and it gives me great pleasure to welcome Konstantin Hyppönen from the Commission, who's going to summarize the broader European view. If you don't know Konstantin, he's a program manager in the digital space for the European Commission. So, Konstantin, welcome to the stage. I'm going to ask Ian how we're doing for time, because I've lost track.
That's right. We're good.
Thank you very much for the introduction and for hosting this event. Indeed, my name is Konstantin Hyppönen. I come from DG Connect. I'm program officer, and Connect stands for Director General for Communications, Network, Content and Technologies. So indeed, it's taking a much broader view on the digital aspects than just digital health. And due to a force majeure, I am in fact replacing some of my colleagues. So I thank very much the organizers for your flexibility today. And this morning, I would like to offer you a European perspective on digital health in terms of where things stand from the legislative and regulatory perspective, but I will also mention some financial instruments which are funding actions which we are supporting, and we'll also take a broader look a way forward ahead. So let's see if I can operate the slides. Yes. Digital transformation in healthcare. The organization of healthcare is, of course, it's the responsibility of member states, but the Commission also has a lot of broader goals in the broad sense, and these goals have been very ambitious, especially in the last years when many pieces of legislations were prepared and also passed, and these form the necessary building blocks for this digital and innovative society in the future, for supporting the transformation in many sectors. So just to name a few horizontal elements, it's the Data Governance Act and Data Act, but also the EU Digital Identity Wallet, which was an update to the eIDAS regulation. Cybersecurity package, which is important for supporting trust, just to name a few. And these broader context, of course, has a direct bearing on digital health by laying the foundations for this advanced progress in the area. And of course, the EHDS regulation was already mentioned today. It's going to be very consequential in the upcoming years. So what are the building blocks that we can use for the digital transformation in healthcare? We need them. We need them for the effective implementation of all these measures, and these are going to be instrumental to achieve a real and significant transformation, not just digital transformation for its own sake, but to have impact on our health and care systems. You can see there are many building blocks. I will not go into detail of all of them, but I will mention maybe a few. So first of them is the EU's Digital Decade policy program, and it does have one element, at least, of relevance to healthcare, and that is the e-health target of having 100% of EU citizens with access to their electronic health records online by 2030. We are monitoring the progress in this subject, and the result for 2022 is 72%, which is not bad at all, but we are still finalizing the numbers for 2023 year exercise, and of course reaching the last miles is always the most difficult part, so getting to 100% in line with the targets of the EHDS as well. At the heart of digital transformation is, of course, high quality data. And the recently adopted European Health Data Space Regulation has been a milestone in digital health policy. It's going to take health data access by EU citizens, but also by other key stakeholders to completely next level. I will be speaking about the EHDS in a few next minutes, but indeed, putting citizens in control of their own electronic health data, which will support their also free movement and continuity of care across borders, but also in the national context. That is really a game changer. The EHDS will be also a trusted framework for the safe reuse of health data by researchers, innovators, policymakers. It's the secondary use, and the industry will also benefit from the EU-wide market of electronic health record systems, opening the door to the discovery of new groundbreaking products and tools. The Data Governance Act and the Data Act will contribute to guiding in a more horizontal way the health data exchange and the access within the European health data space. So importantly, the Data Governance Act sets the rules around data sharing in that horizontal context, and that is a key enabler to the success of the EHDS. And the Data Act clarifies who can create value from data and under which conditions this value can be created, including, especially relevant in the health domain, is the data altruism. Going to the second line, security and trust. So every time we're speaking about the use or reuse of health data, security and data protection are fundamental to gain public trust and to ensure also uptake of these instruments. So the EHDS introduced security criteria for both the primary and secondary use. There are many elements, including, for instance, secure processing environments in secondary use. But also data protection is, of course, building on more horizontal legislation, notably the GDPR. To support the security part, the Cyber Resilience Act provides essential requirements for products with digital elements, and many EHR systems will be classified as such product. So the HDS will set the framework for performing this certification, but of course the essential requirements will come from the Cyber Resilience Act. I mentioned already the wallet and the revised eIDAS regulation, and that will provide a trusted framework for secure electronic identification. And our vision is that citizens will be able to prove their identity and access their electronic health records using their digital wallet, using their mobile phones. And last, at the level of the healthcare systems, the updated NIS2 directive will contribute to increasing resilience of health systems, for instance, at the level of hospitals. Technology and safety. When thinking about the reuse of health data for research and innovation, but also primary use of data, regulations like the AI Act and the revised medical device regulation come into play. In particular, the AI Act is going to support the safe use of health data in AI-driven tools and systems through a risk-based approach. And given the vulnerability and sensitivity of health and health data, many of such systems are likely to be classified as high risk, and therefore they will fall under the AI Act. Meanwhile, the updated medical devices regulation regulates medical devices, including not only devices but software, throughout their whole life cycle, and again, it's based on a risk-based approach across their whole life cycle, from the inception to use. And in some cases, the MDR will apply jointly with the AI Act, for instance, in case of medical devices with high-risk AI systems. Altogether, I think it's important to understand that we cannot think in silos, taking each of these building blocks just as one piece, but we need to exploit the potential synergies between them and complementarities between them if we want the full implementation of the digitally enabled health systems. It's a very big set of instruments and building blocks, but of course there is also funding which is offered through multiple instruments. So the Commission is supporting digital health also through concrete actions under several funding programs. Horizon Europe, which also includes the Innovative Health Initiative, Digital Europe, and also EU for Health. Now, in Horizon Europe, the Commission is funding for different actions for research and innovation under Horizon, and it covers multiple areas. The lion's share of funding for digital health aims at supporting actions to unlock new digital health tools, technologies, and solutions, and that is the largest focus area. There are 6 calls published since 2021. For instance, under 2023-2024 work program, we issued a call on data management, and that is going to support 5 projects that integrate and use health data from different sources like electronic health records, but also genomics, medical imaging, laboratory results, and more specific areas of electronic health data. And that is for the benefit of patients. Another call is on point-of-care computing. What does it mean? There are 4 projects under this call, and it will, these projects will develop and test innovative point-of-care applications, including robotics, photonics, sensors, but also AI, which is very relevant change which we are all observing, and AI was mentioned already in today's previous presentations. It will provide clinicians with real-time information for improved diagnosis, treatment, intervention, and also prevention. I will mention a couple of infrastructures who are funding under the Digital Europe program. And to conclude on the funding, just to say that that EU for Health is one of the key financial instruments for supporting the implementation of the European health data space. 270 million euros have been earmarked during years 2021 to 2027 to contribute directly to the implementation of the EHDS. And for example, it's providing grants for member states to set up their national contact points for digital health, to set up health data access bodies, but also to improve semantic interoperability, for instance, supporting them to start using SNOMED CT. So that is happening under the EU for Health. The Innovative Health Initiative, it's a major public-private partnership funded under Horizon, and it will have received 1.2 billion from the European budget until 2027, of which 300 million are already allocated, 16 projects, and there are calls after call. Today, one of the calls is actually closing, call number 7, which is on heart disease and biomarker validation. But of course, IHI calls have been supporting many other aspects on cardiovascular diseases, on the integration of patient-generated health data, and so on. EHDS. Mentioned already a few times today, and that is really a big change with 3 elements. One of them is primary use, one of them is secondary use, and requirements for EHR systems is the third one. The negotiations on the European Health Data Space Regulation, they culminated in the vote by the European Parliament less than a month ago, on 24th of April. And now the regulation is ongoing its last stages of the legislative process, with the entry into force foreseen in autumn this year. Primary use, it's all about putting the patients in the center and ensuring that their data can follow them if they use the services of different healthcare providers within their own member states, but also across borders in other member states. In the domain of secondary use, researchers and other data users will be offered a unified process that will be implemented across all member states that will enable them to apply for data they need and to get access to that data in a trustworthy way. Advancing science and creating innovation for the benefits of the whole society. And finally, to provide EHR system manufacturers with an easier access to market across member states. Strand number 3 will introduce harmonized requirements for interoperability and logging components, and this increased interoperability will of course also contribute to facilitating data sharing, saving money and time for patients, reducing switching costs in case of EHR system changes, decreasing vendor lock-in effects. How would citizens benefit from the EHDS? The answer is they will benefit from a set of new rights to their electronic health data. They will be able to access health data online through portals or apps, or authorize another person to do so. They will be able to download a copy of their data in the European format and have it accepted elsewhere. Where they spot mistakes in their data, they will be able to request rectification of these mistakes, again online. And yes, they can be in control of their data, they can set access restrictions, they can see who has accessed their data, and also the insertion of information into electronic health records, it's going to take the interaction between healthcare providers and patients to a new level. Data sharing is an important element of the EHDS, so that the treating health professional can get access to the data of the patient they see, and that is regardless of where the patient is coming from. So that is really important, keeping in mind, for example, that case Don was bringing before to our attention. There are two sets of data categories under the EHDS. One of them is the priority categories, and there are 6 of them. And all the rights listed on the previous slides, they need to be implemented for the priority data categories. There is also the second set of data categories, additional data categories, and there is a possibility to define the European format for them. There is a possibility to implement the right for them, and that possibility is up to member states to use. The exchange may be also enabled in the cross-border context where it's supported. Speaking of cross-border, the European Health Data Space sets a cross-border infrastructure for data sharing, and it's operational already right now. It's operational in 13 member states, and more are to join already this year. Currently, the infrastructure is supporting the exchange of patient summaries and electronic prescriptions, but it's to be enlarged to support all the priority categories of health data. And member states are running projects to expand the data content. There are 2 important new possibilities for the My Health at the EU infrastructure under the EHDS. First, it's possible to connect other infrastructures to My Health at the EU, for example, some international infrastructures. And second, it's also possible to connect third countries, but of course only where necessary prerequisites are met. And one important prerequisite is, of course, the sufficient level of data protection and security, which has to be verified using a compliance check. So we can never risk security and data protection when doing so. The data is exchanged in the European format, health record exchange format. And what is that? There is a whole article on the format in the EHDS regulation. I'm not going to read it aloud today to save a little bit of time. But what is important to notice is that the format will be laid down as implementing acts, so legal instruments. And the format is expected to include harmonized data sets, coding systems, and technical interoperability specifications for all priority data categories. And the format can also be expanded to additional data categories. Also, the format is not only about structured data, but it has to support both the structured and unstructured data. While of course, structured data is normally of higher quality, it's important to enable natural persons to exercise their rights, even if the data is not perfectly structured. In some data, in many cases, that is still much better than no data. You may ask how the specifications for the format are being developed. While it's for the Commission to adopt the implementing act, formally setting the format, a lot of preparatory work has been already performed in previous projects and also ongoing projects. You can see a few of them on the slide. Just to mention Expand-EH, X-Share, funded under Horizon, and the joint action XT-EHR, which is funded under the EU for Health. The latter will develop recommendations for the format, drawing together the results of many previous and ongoing projects. And the format will be implemented in My Health at the EU and also in all EHR systems placed on the Union market. Support actions will be running to offer help to the implementers in both contexts, in My Health at the EU and in EHR systems. On secondary use, that is to enable researchers and other data users to access health data for their legitimate purposes. There are allowed and disallowed purposes under the EHDS, and a unified process will be established by member states to enable access to data. So the process starts with data discovery, enabling the user to see what is the data available, and the data is described in the metadata catalog. After discovering the needed data, the data user can submit an application using a harmonized form, and if approved, the data user will get access to the data in a secure processing environment. There are also some obligations for data users, for instance, to publish the outcomes of the research in the format of lay summaries that could be understood also by the broad public. There is an infrastructure for secondary use upcoming, and currently there is a pilot which is approaching its end in September 2024, which is showing the added value of health data at the infrastructure, for example, in antimicrobial resistance surveillance, or in cancer, or in COVID-19, or in cardiometabolic diseases. So multiple use cases are being piloted in that pilot. And recently, many member states have launched already projects for setting the health data access bodies, supported by grants from EU for Health. And also, one of the joint actions, TEHDAS, has ended. One more is upcoming to enhance collaboration of member states in this exercise. The last element of the HDS is the requirements for EHR systems, namely for two components. One of them is interoperability, and another one is for logging. The goal is to somewhat decrease the market barriers to enable EHR system manufacturers to easier place their products on the markets of different member states, increase harmonization overall. The entry into force of the HDS regulation is expected to happen around end of this year, and entry into application 2 years later in autumn 2026, but many elements will only come, they will see the light in 2028 or 2030, so there is a well-defined structure for different steps of the implementation. It's going to take several years. And the last elements, such as the connection of third countries to health data at the EU, it's around 2034, so still in around 10 years. Now, the last topic I would like to mention today is a few research infrastructures which are supported under the Digital Europe program. These research infrastructures, you can see them as one way of going deeper on certain types of electronic health data, notably for secondary use of the data. And that is 1+Million Genome Initiative, Cancer Imaging Initiative, and also Virtual Human Twins Initiative. 1+Million Genome Initiative has been set up because genomics has the potential to revolutionize healthcare, taking personalized and precision medicine to a whole new level and allowing for targeted prevention strategies. The 1+Million Genome Initiative aims to make the most of these benefits by enabling secure access to genomic data across Europe. It started already in 2018 when 25 EU countries plus the UK and Norway signed a declaration to step up their efforts in building a European infrastructure for genomic data. And that is becoming reality through the genomic data infrastructure. It's a 40 million project that builds on that solid basis and creating the roadmap for the implementation in the future. It will be a federated infrastructure enabling cross-border access to genomic and related clinical data, and it includes organizations from 24 member states or European countries. One more important part is the Genome of Europe database. It's one of the pillars of this 1+Million Genome Initiative and spans across 26 countries. It will likely start later this year and will establish a European reference genome based on the whole genome data of 100,000 representative European citizens. So it's a major undertaking. Second one is the European Cancer Imaging Initiative, which is looking at medical imaging data in more details, one of the flagships under Europe's Beating Cancer Plan. And the cornerstone of that initiative is the Cancer Image Europe infrastructure, developed by the EU-CAIM project, building on the results of the work of 5 large Horizon 2020 projects from the AI for health imaging. So this federated infrastructure will link up resources and databases to make millions of cancer images available to researchers in a safe, privacy-preserving way, and also with sufficient metadata to analyze them and to use these images for research and innovation. One of the milestones, which was achieved last year in September 2023, it's the Cancer Image Europe infrastructure. So as of today, the Cancer Image Europe platform links up 39 datasets of images of 9 cancer types for a total of over 200,000 image series of about 20,000 individuals. It's 21 clinical sites from 12 countries today, and by the end of the project in 2026, the goal is to have at least 30 distributed data providers from 13 countries. And this project is expanding as well, so there is a call for additional beneficiaries to join the consortium, and a few member states have expressed interest in establishing European Digital Infrastructure Consortium, it's called EDIC, to sustain the platform. The last initiative I want to mention today is the European Virtual Human Twins initiative, and that was announced in December 2023. It's the EU framework supporting the emergence and adoption of the next generation of virtual human twin solutions in health and care, and as digital representation of the human body that are built using software, data, and AI. Virtual human twins, they hold a great potential for personalized and predictive medicine, and that was clear when we saw that the VHT manifesto was signed by more than 75 signatories across industry, academia, and research in December 2023. So now we are in the process of establishing the advanced platform for VHT models. There is a call for tenders currently open until 7th of June that will start developing this platform for integration and sharing and validation of VHT models. There is one more data space or infrastructure upcoming for intensive care unit, but I'm seeing my clock is ticking, so I will not go into more details on that part. Just to mention that it's all adding more, say, verticals to the EHDS secondary use, going deeper on certain types of data. So what's next? The current Commission has been very productive in defining different legislative instruments, and it's going to take quite an effort to implement all that during the next years. So we already saw the timeline for the European Health Data Space, and of course there are timelines for also other types of legislative instruments. So it's going to be quite an effort. I think I will not go into all of the honeycombs here on the slide, but you can see that it's actually making sense when things are being put together. They are not separate, but they are complementing each other. And we hope that with this impressive set of instruments and also support actions, we will be able to develop digital health in the EU, support digital health solutions in the EU, help them reach the market, and support the EU to become competitive globally. So let's continue collaborating to drive forward the digital transformation of healthcare for the benefit of European citizens and our whole society. Thank you very much.
Konstantin, fantastic. I'll take a seat there. So, that's our 3 introductory talks with a fantastic amount of detail to work through. And I open the floor to you to ask questions to either of the 3 speakers. If you want to nominate somebody to answer, that's fine. Otherwise, I'll direct it to who I think might answer best. And Ian's keeping a close eye on our Zoom constituency, and I don't know if there are any questions there yet, but so I'm looking for questions. It would help enormously, as I say, if you wait till the microphone arrives, and then just introduce yourself so we have an idea of who you might be.
Yes, thank you. My name is Robert Stegway. I'm chair of CENTC 251 Health Informatics, one of the SDOs contributing to the electronic health record exchange format. I'm very honored to be here and very impressed by the introductions. And my question to the panel would be, if we want to exchange data using SNOMED CT in the electronic health record exchange format, as we're already doing in the IPS, hopefully, does that also mean that we need to enter the data in our EHR systems that produce this data in SNOMED CT, or do you see different ways forward to making this happen?
Who's going first?
That's a really good question. You should have told me that before when we were out there having a coffee. I would have to say, I think that the electronic health record systems will evolve so that if you have data that is in, if you will, national terminologies that have been developed over the years, and a country wants to keep that, then essentially the question would become, can the EHR itself as a software evolve enough to link those terminologies with what SNOMED CT brings? There is certainly, from a unstructured data perspective, there's all kinds of new things coming out that it is unbelievable that doctors can dictate in their usual, and I know there's a lot of doctors in the room probably, so I'm going to offend them, in their usual rambling way, somewhat the way I do my presentations.
Easy there, easy there.
And in the end, there are dictation systems that can effectively structure that using SNOMED CT codes, and even go a step further and provide discharge notes that are structured and unstructured, which then allows clinicians in a certain practice, or if you will, specialty, to then say, okay, we've all rambled differently, but the discharge notes look eerily similar. Let's have a standard discharge note. So I think that will happen. The key is, and I think this has been something that's been talked about since probably the last 20 or 30 years, is we have a number of standards organizations and groups that are working very, very hard to codify the data. We, as a ecosystem of those organizations and those people that are doing that work, need to come together and find a format that allows it to happen. Eventually, one would hope that you have one code that you can use many times. And it's not my saying. If Stephanie's in the room, it's Stephanie's saying, and I believe it. You can use different standards. Different standards have different purposes, but they must link together so that in the end, when you're looking at the record, it looks consistent from a standard perspective. I don't know if that answers your question, Robert, but I tried.
Nick, do you want to have a go at that from a sort of Belgian point of view? I think it's too complicated to maybe just Belgium.
I know, but I will look at Tom. You have in Belgium for physicians a specific standard that is used. David also know probably. A specific standard that is used and that is then translated into SNOMED CT. Because they are more familiar with that, it contains the concepts that they really need in their daily practice. For me, the focus, the aspect is it has to be user-friendly. And I hope you will have systems that make it easy if you have to select among 100 possibilities in your value set, which one is in relation with, I'm not a physician, excuse me, I'm not medical, so I'm going to say bad things or wrong things, I guess, but is related to the diagnosis or things that you want to register, then this is worrisome. So it should be easy. It should really be easy. If you will have language interfaces, I don't know. If ChatGPT will help us in the future, I don't know, but it should be made easy. And of course, the exchange, the one who uses the data has to understand the same thing. That is also something that is, has to be taken care of, because that is also not something that is easy, I have understood.
Thanks, Nick. I suppose my comment on this is that when Nick was talking, he talked about chocolate and beer, but there is one other thing that the Belgians are not bad at, and that's football. Now, we all understand the game of football. Every game of football is extraordinarily different, but it's played to a common set of rules that everybody understands. And I think what's being described in all three presentations that we've had this morning is that there's a journey to that point. It would be wrong, I suppose, to call medicine a game of football, but you get my general gist. Okay, are there any other questions? Any online? So I have, while he finds one on Zoom, I do have a question about the practical application of, I think what you were talking about, Nick, which is turning SNOMED into diagnosis-related groups, or in the UK, health-related groups. And I've tried to argue that in my patch of London for many years, that we should use SNOMED for a practical thing that produces money, because that's what drives people to do stuff. And is SNOMED somewhere being used in Belgium to produce a DRG or a DRG type of billing system?
I guess I have to answer that one.
Yeah, you do.
To be honest, I do not dare to confirm. I don't think so. Tom is shaking no. So I'm going to repeat what he's saying. No, it's not used. But we are examining it as a possibility. If it's usable in a DRG, Belgian related terms, if it's usable in a DRG system.
Great.
Under examination.
As you know, our country have excluded ourselves from this party, but if I can join yours, I would be I'm very grateful. Right.
Charles. Charles, in relation to that, there is an example in Canada, because I know you're all about the money. In my home province, the doctors are actually agitating to have SNOMED CT generate some of the information to allow them to actually not only justify the money they get for doing certain procedures, but also to potentially modify those codes based on the severity of a procedure or procedures. So there is a lot of work underway in various hotspots that are looking at that, driven not by the government, obviously, but by the clinicians.
Yes, and I do think there's an example in the UK, but it's a slightly different one, which is, as you may or may not know, every single general practitioner in the UK uses SNOMED CT to record the information about every patient. And one of the driving factors of that, right from the beginning of time, was that in order to earn more money as a GP, you have to complete an annual report on all of your registered patients called the Quality Outcomes Framework. That is the only way you get that additional fraction of money as a general practitioner. There are no incentives in the hospital system, the same thing. So we, like everybody else, base our bills on ICD-10. And there are consequences for that, which is that the data at a population health level that comes from hospitals is less interesting for research, for population development, and so on. And I don't know how to make that switch to latency. So I think I'm getting signals from my boss here that it's time for me to shut up. So I'm going to shut up, but I'm going to give Daniel just one chance to ask a question, because you've just put your hand up. So Daniel.
Thank you. If you summed up the numbers on Dr. Hyppönen's slides, there was an impressive amount of cash involved. And relating to Robert's question and Don's question, so this seems like a bet that artificial intelligence will not replace e-health standards before 2036 was the last year on the slide. Is that correctly understood? And what's the perspective there? Thank you.
Thank you for the question, Daniel. I think it's not about replacing electronic health records. We are really interested in getting access to electronic health records and having the records follow the patient wherever the patient is going, having the records available for secondary use purposes. But I think there are possibilities which can be offered through the AI. I think it was Nick who mentioned that we should get rid of drop-down boxes at some point, and that's one example of how AI could be helpful. But also there could be some other examples. For instance, we are currently funding one project that's called IDAVA, which is looking at consolidating patient files for both primary and secondary use using AI. So analyzing data from multiple sources and bringing the data together into a common data model. So that's one more example of how AI could be used. So we could explore possibilities for different co-pilots for health professionals, helping them enter the data, or maybe get summaries of previously collected data, because unfortunately we are also getting feedback from some of the stakeholders that there is too much data. And it's so difficult. I don't have time to read through all that patient history of spanning multiple years. So maybe, again, AI could be useful to get some insights from the history of the patient useful for that specific case. So it's not about either or, it's about complementarity in my view.
So thank you very much for that. Can I ask you all to raise your hands again for our three introductory speakers?